Thank you all again. So prior to having Joe come up to give us some closing remarks from the Obesity Action Coalition, we're actually going to watch yet another video from the patient's perspective, speaking to healthcare bias and even encouraging self-advocacy.
Obesity to me was always presented as a choice that I was making. It was something that I was failing to do versus something that I was failing to receive. It's also the really hardened internal bias that individuals go into doctors' offices with. They walk in with a lot of shame and blame about their weight. If you aren't willing, my experience is if you do not advocate for obesity treatment, you will not get it. In my early 20s, I had bariatric surgery. And then when I went back to my doctor, I started getting attention for other medical issues besides my weight. It was like they now see me as somebody who was taking my weight seriously where I wasn't before. We have to build a level of comfort of saying really hard things to people who impact the quality of our lives. And I think the only way that we're going to see change in the United States with obesity is to start calling folks out.
Thank you. Joe.
So I get to go to a lot of these meetings. In fact, I've been on the road 2 straight weeks doing meetings similar to this. And I just want to compliment the organizers on what I thought was a really well done, comprehensive meeting. Might be reflective of all the talent and amazing professionals, both healthcare providers and researchers you have here in the state, but it was a beautifully well done session. And I think about what we've heard so far, and I'll just offer a couple observations and then a few closing thoughts. But this is about real people, and for those real people, this is biology, not blame, right? We heard that from the patient stories. You heard that remarkably well said in this last panel about how much those people and them sharing their stories really meant to us and influenced us. But it's also important to recognize that we need further innovation, right? I will say in my own life, I mentioned earlier that I've been on 17 behavioral programs. I've also been on 5 medicines. Now, this current generation of medicines, a lot like the ones we talked about today, the GLP-1s, I'm benefiting from one of those. But I hope to live another 40 years, and it might be that I need different medicines moving forward. So I would encourage you to keep up that innovation. Don't rest on your laurels, right? We have work to do in this space moving forward. And then again, unless people have access to these medicines, they are not the game changers we talk about. There are 100 million plus people in the US who have obesity. There are 1 billion people around the world. There are a couple million people right now who have access to these medicines. We're not nearly helping enough people. We have to change that. So we have to create access. We have to make it so that these benefits, this coverage for these things are standard. And we also have to make sure the healthcare system is prepared to care for them by offering comprehensive care for people with obesity. A couple observations from the day. Usually when I go to these, there's a debate about whether we should focus on prevention versus treatment. We didn't have that today. I think that's a good thing, because you know what? It's not one or the other. We need both. I live in Tampa, Florida. I have to wear sunscreen every day, from the Florida sun. But if I develop, so I put it on every day, but if I develop skin cancer, my doctor doesn't just tell me to keep putting on sunscreen. He does something in addition to that, offers me other treatment. With obesity, we have the tendency to say, just keep doing the same thing that didn't work before, right? Keep doing the same thing to prevent. And that has to change, and I think we're starting to see that. One of the realities is, many of us, myself included, are sometimes skeptical about our prevention efforts so far, because most of them have failed. That doesn't mean we don't have to continue to do those, though. We have to make the healthy choice the easy choice for most people. We just need to, again, as Dr. Allison said, get out of the box, right? Think about something different. We need to look at this in a different way. And we need to innovate there, just like we are innovating around treatment as well. Another observation from the day, and I'll just be frank here, there's some language used when we talk about obesity that I would encourage you, that we can use in this closed environment, but I would encourage you not to use in the public environment. And that is the word obese. We know from study after study, people with obesity don't like to be called obese. You would never say to someone who's cancerous, you would not label them as cancerous, right? We are not our condition. So if I can leave you with one tip today, is to strike that word from your vocabulary. Just say a person has obesity. We don't need to use that language. It is easier. And by the way, if you're a healthcare provider and you're talking to someone about their weight, ask that person how they want to be referred to. Let the person who's actually struggling with the condition do that. I will say that I know people who can do this, who they can switch between never using the word obese to a patient, but then use it in a private session. And I'll be frank, it took me 2 years to work the word obese out of my vocabulary. Not doing it. It takes practice, so I want to be clear there. But let's not let language be one of those subtle ways that drives a person who's struggling with this from seeking help from you, especially if you're a healthcare provider. Last panel, there was a question asked about diversity in clinical trials, and just something that I'm going to mention here because I think it's important. So for trials beyond obesity and diabetes, we often exclude people from obesity from those clinical trials. And I want to challenge you not to do so. We have plenty of medicine. People with obesity struggle from 250, 260 conditions associated with obesity, and they use lots of medicines for lots of other things. But if you actually haven't studied those medicines in people with obesity, it's a challenge, right? We know of medicines that exist now that either don't work well enough or work too well. There are medicines that get stored in body fat and adipose tissue, and they may actually work too well in people with obesity. So I'd encourage you, it's just a simple thing as you're designing trials or thinking about your next medicines to make sure you're including diverse populations. I know it's challenging, and maybe there's some lab tests you can run to prove that body fat doesn't affect these medicines and it wouldn't affect, but think about it, right? You have to have a plan to do that moving forward. So again, a couple things going forward. My closing remarks, we'll keep this short so we can go to the reception here in a few minutes after one more presentation. So what can you do? What can you do today? So a couple things that I would encourage you to think about. One is to do, when we talked about bias and stigma this morning, think about that. Take a look at your own behaviors, your own actions, challenge yourself to be better. And then challenge your family and friends to be better. Take a little bit of what you learned today. Again, I don't believe in blaming and shaming them. Talk to them about the complexity of this issue moving forward. The other thing you can do is advocate for access to these treatments. So we saw Senator Young here earlier, who is a longtime supporter of the Treat and Reduce Obesity Act, which is legislation that is before Congress and that would actually impact people on Medicare. So if you're a Medicare recipient right now, you can only be counseled by your primary care provider, or you can have bariatric surgery. You can't be counseled by other specialists, nor can you access these medicines. That legislation would change that. We have an opportunity here at year end in what's called lame duck session, and then moving in the next year to actually get that legislation passed. The Congressional Budget Office just released a report, and they said it would cost $35 billion to do that over 10 years. And a lot of people think that's a lot of money. But during that same 10 years, we will spend $1.5 trillion on other medicines. So $35 billion is a rounding error, right? People deserve access to this. And by the way, we have other studies that show those medicines will save about 40,000 lives annually. I think that's worth that $3 or $4 billion a year over 10 years to make that happen. And another thing you can do is look at your own health plan and start advocating within that, whether it's within your employer or if you have a fully insured plan with an insurance company, and say, hey, are you covering these treatments? And if not, why? Because there are real people, many of them who you met today, and me, who need access to these treatments. And again, I think half of us today, those of us who shared our patient experience, talked about how these medicines aren't covered by our insurance, that we have to pay for it out of pocket. I'll go even farther than that. I've been doing this, I've been struggled for 30 years. Not once in those 30 years has my health insurance helped me with my obesity. Yet I'm saving them thousands and thousands of dollars right now by having addressed my obesity. So again, I want to thank all of you. I want to thank you all. I hope you learned something over the day today, and really just keep that person with obesity in your heart. Show them a little compassion and empathy, and it'll make a big difference in their lives. Thank you very much.